Bismillah ar-Rahman ar-Rahim. We are delighted tonight to have this educational program sponsored by Pfizer. It's called Circulate, 1st of November. And discussion tonight will be about the stroke prevention in atrial fibrillation. And I'm very delighted to have with us tonight very well-known speakers. Dr. Hussein Asmat is a consultant intervention cardiologist. Apparently just moved to the new hospital,
Yes.
Tidawi Hospital in Dubai. And
Yes,
also I'm delighted to have Dr. Amir Faour. He is also consultant cardiologist at Medcare Hospital in Dubai. And the discussion, as I said tonight, will be about the stroke prevention of patients with atrial fibrillation. And as we all know, stroke is one of the most dreaded, most serious complication in cardiovascular disease. And actually, many patients, if you ask patients, many patients, they'd rather to die, not to have a disabling stroke. Really, the quality of life of somebody have disabling stroke is really very bad. Not only them and all and the family. So a stroke is a really one of the most kind of serious complication in cardiovascular disease. I have a few kind of statistics about the stroke. I just look it up. And in 2021, 1 of every 6 deaths from cardiovascular disease was due to stroke. And about every 40 seconds, somebody will get a stroke in USA alone. And every year, there's about almost a million person sustain a stroke, and 1/5 of them get recurrent stroke. 87% of the stroke are ischemic. And as you all know, most of them are embolic. And atrial fibrillation is one of the most stroke. The cost of a stroke is horrendous. It's in 2018 to 2019, it was $56 billion in one cost, indirect cost of having a stroke. So that when we try to look at some cost effectiveness of any disease, any medication, we have to look at the whole picture and see what is the risk of not giving a particular medicine. So tonight we'll be enlightened by the 2 speakers about atrial fibrillation kind of overall, and how we can prevent stroke in patients develop atrial fibrillation. I mean, as you know, atrial fibrillation come in different form and shapes, persistent, intermittent, chronic, and so on. But I think there's another way to look at it. There is symptomatic atrial fibrillation and asymptomatic atrial fibrillation, and that is a problem with asymptomatic. Patients have the disease, and the first presentation can be a stroke, and it can be deadly or can be disabling. So we're going to start with Dr. Hussein to discuss the idea of the stroke. The exact title of his talk will be
screening.
Sorry, I just have it. Screening for atrial fibrillation in basically silent patient. Dr. Hussein.
Thank you, Dr. Omar, for the kind introduction.
Dr. Hussein, all is yours.
Thank you, Dr. Omar, for the kind introduction. And thanks for the
Thank you.
And thanks for the organizers for inviting me. It's always hard for them to take part of their precious evenings to attend such virtual events. So I hope that what I present to them tonight would induce some changes, useful changes in their practice. So today I will be talking about screening for atrial fibrillation. And first, these are my disclosures. And we will be discussing the concept of screening in general in medicine, and how does that apply to atrial fibrillation? Who should be screened for atrial fibrillation? And then what are the screening tools for atrial fibrillation? What are the benefits of screening for atrial fibrillation? And after atrial fibrillation, how can the digital devices help us in managing these patients? So first, let's start by the concept of screening. Screening means trying to hunt a disease that is silent. And in order for screening to be justified, we need to fulfill some criteria. Because the difference between screening and a screening test and a diagnostic test is that the screening test is done for someone who doesn't have symptoms, who doesn't have any complaints. So the screening test needs to be justified, and I will explain that. First, the disease that we should be screening for must be common among that population. If we go and search for rare diseases among an entire population, then we will be spending a lot of money and not getting anything, not getting even cases. Number two, the disease must be serious. We do not screen for flu, for example. Number three, the disease has a phase that can be silent. For instance, we do not screen for shock, because shock can never be silent. And the early silent phase of that disease, we have some tools that can change the outcome. Moreover, the disease should have a screening tool that is affordable, that has a reasonable accuracy, and the screening test is safe. And number six, the disease, of course, should have a form of prevention or treatment. So let's take some quick examples to refresh us and see in these situations, is screening justified or not? So let's look at some examples. Screening for breast cancer among men doesn't make any sense because it's extremely rare, so it's unlikely that we find disease. So screening here is not justified. Screening for COVID in the pandemic, of course, it makes sense because we're looking for a common disease that is serious, silent, preventable, and cannot be cured but can be prevented. Screening for colon cancer makes all sense because we're preventing a serious disease. Screening for lung cancer among smokers, it's controversial because the carcinogenic risk of radiation may equalize the risk of the screening itself, so it's a question mark here. Screening for silent coronary disease among diabetics again is questionable because screening can have fallacies, can result in many tests unnecessary, and we know that stable disease is managed conservatively. Screening for LV dysfunction after breast cancer chemotherapy, yes, because it's common, can be fatal. We have nice screening tools and we have therapies that can modify the course of the illness. So let's see how do these things apply to atrial fibrillation, keeping in mind that there's more than one screening strategy. Systematic screening means screening everyone. We go to an entire population, let's say school children, and we screen for a disease. Screening in high-risk groups, we choose a special group of patients who know that these conditions are associated with the disease, and we go screen every one of them, like stroke patients. And another form, which is called opportunistic screening. So we take the chance. A patient is coming for vaccination, for example. So we measure their blood pressure. That's screening for hypertension. A lady is coming for routine antenatal care. So we screen for a form of malignancy. These are called opportunistic screening. How do these concepts apply to atrial fibrillation? First, is atrial fibrillation common? We'll understand the prevalence of atrial fibrillation. Is atrial fibrillation serious? We'll discuss the morbidity and mortality. Can atrial fibrillation be silent? Yes, and we will describe the phases of atrial fibrillation. Do we have good tools for screening? Yes, we have plenty of tools for screening. We will discuss the advantages and disadvantages of each one. Can screening prevent atrial fibrillation complications? We will see what literature do we have on that. Is there a treatment for atrial fibrillation? Of course, yes, and we will not be discussing that. So let's start by the prevalence of atrial fibrillation. It's not uncommon, and we see the highest prevalence is in North America, whereas Africa and Middle East, they have a relatively lower prevalence of disease because of the lower age and because the lower hypertension and other atrial fibrillation comorbidities. But we know that the prevalence of atrial fibrillation increases with age. So if we take a population that is less than 50 years, then the chances of finding atrial fibrillation will be extremely low. Then it doesn't make sense to screen young asymptomatic individuals for atrial fibrillation. Starting at between 60 and 70 years, we see a sharp rise in the prevalence of atrial fibrillation. Then it makes sense to screen the elderly population for atrial fibrillation, because if we look at those at the age of 70, then we will have 10% atrial fibrillation. At the age of 80, it may be 20% prevalence of atrial fibrillation. So this answers one part of the first question: who should be screened? And then we know from that curve, it should be the elderly population. Looking also at comorbidities like heart failure, diabetes, and hypertension, we see that the prevalence is higher whenever there are comorbidities. And that gives us another clue that elderly patients and those with comorbidities deserve screening for atrial fibrillation. Because atrial fibrillation is a serious condition, it can result in mortality, it results in stroke. Roughly 1/3 of all strokes are induced by atrial fibrillation, and the strokes that are caused by atrial fibrillation are usually more disabling. Atrial fibrillation is associated with dementia, Alzheimer's, associated with depression, impaired quality of life, and increased heart failure risk. So what are the risk factors for atrial fibrillation? Age is probably the most common. Male gender is a risk factor. Obesity, sleep apnea, COPD, diabetes, hypertension, dyslipidemia, alcohol, of course, and smoking. And that gives us a third clue for those patients who need to be screened: the elderly and those patients with one or more of these comorbid conditions. The third population that deserves screening are those with cryptogenic stroke. Stroke without a clear cause, without clear atrial fibrillation, without endocarditis, without hypertension or diabetes. Especially that we expect that those patients with cryptogenic stroke, between 20 and 30% of them, if they are screened for a long period of time, we will be able to catch atrial fibrillation. So we screen the elderly, the ones with comorbidities, and those with cryptogenic stroke. Let's look back into the natural history of atrial fibrillation. Atrial fibrillation starts at short bursts of very high atrial rates. And these are short episodes that are usually not noticed by the patient. And we began to understand that as the number of patients with pacemakers started to increase. So we are now able to detect let's say, precursors of atrial fibrillation. Then if these are left alone without control of risk factors, then atrial fibrillation develops in short paroxysms, then the paroxysms become longer and more frequent, then atrial fibrillation becomes persistent, and if we fail to treat it and revert to sinus rhythm, it becomes permanent atrial fibrillation. So we have the chance to screen for atrial fibrillation in the first three types. And these are the definitions. The paroxysmal refers to 7 days, persistent, what is more than 7 days, long-standing is more than 12 months, and permanent is the one that is accepted by the patient and the physician, where we're not planning to revert it to sinus rhythm. Let's look back at the precursors of atrial fibrillation. And we knew that from the pacemakers. Roughly 1/3 of patients who have pacemakers, there is an atrial lead, and this atrial lead is able to capture the activity from the atrium. It's implanted inside the heart. And we know that there is a term that's called atrial high rate events, AHRE. And these are very short bursts of rapid, maybe irregular atrial activity that are not seen by the patient. The patient doesn't feel anything. And because if you do even a 12-lead ECG or a Holter monitor, you may not see them. But because the pacemaker is there all the time, it's able to catch these brief episodes that are less than 6 minutes. And these are probably the precursors of atrial fibrillation. When these episodes are more than 6 minutes and less than 1 day, so we call it subclinical atrial fibrillation. So what should we do about these atrial high rate episodes? We will explain on that in the coming slides. But we know that these atrial high rates are associated with an increased risk of stroke. If we follow these patients for 1 or 2 years, then half of them would develop atrial fibrillation compared to those patients who do not have the atrial high rate activities. And if we look at the risk of stroke, then the presence of atrial high rate episodes is associated with roughly double the risk of atrial fibrillation. The risk is still low, less than 0.5%, but it's more than double of those who do not have atrial high rate episodes. So we saw the precursor of atrial fibrillation, or the subclinical atrial fibrillation. Does the duration of atrial fibrillation affect the risk of stroke? The literature changed multiple times over the last 20 years. Initially, we thought that paroxysmal atrial fibrillation has the same stroke risk as permanent atrial fibrillation. Then we came to realize that no, permanent atrial fibrillation always has a higher risk of stroke compared to paroxysmal atrial fibrillation. And shorter durations of atrial fibrillation are associated with low risk. And the cutoff is probably 5 minutes. So those episodes of atrial fibrillation that last shorter than 5 minutes will not have a significant risk of stroke as those that last more than 5 minutes. So this is from a guideline by the European Heart Rhythm Association that describes the indications for screening for atrial fibrillation. And as we've mentioned, one of the strongest indications is the presence of a stroke. And these patients need all of them to be screened for atrial fibrillation. The other indication is the elderly population above the age of 75. They should be all systematically screened. For those between 65 and 74 who have one or more comorbidities, again, these patients should be screened. If there's no comorbidity, there's no chronic kidney disease, COPD, diabetes, none of these, then we can consider screening yes or no. Below the age of 65 and without comorbidities and with no symptoms, then the screening for atrial fibrillation is probably not going to have any meaningful impact. So opportunistic screening by just checking the pulse for the ECG rhythm gets class 1 for those above the age of 65. And of course, for anyone who has a pacemaker or an ICD, we need to look for atrial high rate episodes because they can be precursors of atrial fibrillation. If you're looking forward to build a screening program for atrial fibrillation, then you need to have an entire structure. You need to have devices, you need to have softwares, and you need to have a hospital environment that's able to manage atrial fibrillation in the form of a team of doctors and nurses, keeping in mind that the screening on its own by any of the devices that we will mention is not sufficient to qualify as clinical atrial fibrillation unless we documented on a single lead ECG for more than 30 seconds or a 12-lead ECG. So what type of devices do we have available to screen for atrial fibrillation. And it's good reminder here that we have 3 or 4 classes of medical devices depending on the simplicity of use and the risk of utilization. So pacemakers are class 3 devices, whereas peripheral vascular catheters are class 2, class 1 are the simple devices. So how can we, what are the devices that can help us hunt hidden atrial fibrillation? We have pacemakers, implantable loop recorders, long-term ECG, short-term ambulatory ECG, and we have other devices, smartwatches, smart bands, mobile phone applications. Let's go through them one by one, keeping in mind that there's a very nice document on the use of digital devices to detect arrhythmia from the European Heart Rhythm Association, and it's a very practical document. And as you can see here, we have 1, 2, 3, 4, we have like 10 or 11 types of devices that can be used to screen for atrial fibrillation. And let's go through them. First, there are 2 main types. One is dependent on a plethysmography, PPG. And plethysmography is the technology that we know is available in the pulse oximeters. It's a light source and it measures changes in the blood volume. And it doesn't generate an ECG, it generates a waveform, and then this waveform is used to calculate a heart rate. And through some algorithms, they can detect atrial fibrillation. Where there are ECG-based devices, and these create an electric recording, not a light recording. And these tools are preferable because they are more accurate. But of course, they need a clinician to diagnose. You cannot count on the artificial intelligence alone. And for the medical devices, the diagnostic kit, of course, improves with a longer duration. So if the patient comes with daily symptoms of palpitation, then a Holter monitor would be enough. If the patient has rare or less frequent symptoms every week or 2 weeks, then an ECG patch would be better. For patients who have symptoms that are far spaced, then an implantable loop recorder would be the only option. The implantable loop recorder is an expensive device, but it can be inserted through a simple procedure in the outpatient. It does not require an admission. And the device can stay in the body for long periods of time, and it can keep recording for several months or even for years. But these are expensive devices and they need a physician to use them. Can we do a portable ECG? Of course, these are the pictures of the initial ECG recordings by Einthoven back in the 19th century. But now there are ECG portable machines that are that small and they are commercially available. You can order them even online, and they can generate a 2-lead ECG or 3-lead ECG. But of course, they need the patient to be conscious. So we cannot give them for someone who has syncope, and they are connected to a mobile phone application, and then they can be sent to the physician. And we also have a commercially available, which is available here in the UAE. There's a patch that can be applied to the patient's chest, and it lasts for 1 week. It's useful for those arrhythmia that do not occur frequently, or if you need an extended window of monitoring. These are very handy patches, and they can be even auto-resistant. Of course, they are more expensive than the Holter monitor, but they are less costly, of course, compared to the loop recorder. And now almost many of us and many of our patients, they have smartwatches. And the Apple Watch, and there's no conflict of interest here, they have the FDA clearance for the use for the detection of atrial fibrillation and the detection of arrhythmia. And just by the mere coincidence, this is one of the patients I saw today. She's a 23-year-old lady who had 1 attack of palpitation, and I saw her using the Apple Watch. So I told her, did you manage to record an ECG? She told me yes, and here's the ECG, and guess what? She had a clear supraventricular tachycardia. We know that young ladies, when they complain of palpitations, we can take them lightly, but the presence of these devices now makes the life easier and makes the life of the patient easier in terms of diagnosis. It's not only the Apple Watch or the Huawei or the Samsung or whatever, but also the bands. We know that the Fitbit, which is a Google product is also FDA approved for detection of atrial fibrillation. There are also mobile phone applications. One of the most famous is called FibriCheck, and these are, of course, plethysmography devices. They use the light of the mobile phone, and they generate like a waveform, and then they can, through the algorithm, give you a hint that you may have atrial fibrillation. And you see here that the sensitivity and the specificity of these devices are really high. It's more than 90%. So I usually rely on them heavily. If the patient can afford to buy one and use one, they can save you sometimes the use of a loop recorder. But of course, the limitation of the ECG-based devices is that they need an awake patient, whereas the band is recording all the time, and the loop recorder and the pacemakers are recording all the time, so they are used for patients who lose consciousness or go into syncope. And you can see here as the frequency of symptoms, if they occur daily, then we can use any device. For those who occur yearly, then a loop recorder or a portable ECG would be the best option. For atrial fibrillation screening, which is usually a condition that affects the elderly, we need to keep in mind that the elderly population are not very familiar with technology. Our children are usually more tech savvy than us. So the elderly population may not be able to use the devices easily. So it's better to give them a smart band rather than a smartwatch if we need to screen for atrial fibrillation. But if we need to do a systematic screening for a patient with multiple comorbidities, then we go for an ECG-based device. Whereas the PPG-based devices are useful for patients with low risk and for opportunistic screening. So we've done the screening and we diagnosed something or we didn't diagnose something. Is the screening useful? Will screening prevent stroke? Can we start treatment based on screening? Let's see. In the latest ESC guidelines on atrial fibrillation, screening can have benefits and it can have also risks. The benefits, of course, that we can start anticoagulation and prevent stroke. We can give arrhythmia, antiarrhythmic therapies. We can correct cardiomyopathy. We can reduce hospitalization, etc. But we need to understand the risks. Number one, the anxiety that we induce. So the patient will be constantly looking at his smartwatch. Did I have atrial fibrillation? This ectopic beat, I forgot to record it. So it creates some form of anxiety. And these AI tools are not 100% accurate. You still need a physician to interpret the result and diagnose. And there may be false positive and there may be false negatives that may result in unnecessary testing. So the consensus by the United States Preventive Task Force for those individuals starting at the age of 50 who do not have stroke, then there's no point in screening. As we said, screening is useful in three populations: above the age of 75, those with multiple comorbidities, especially if they have symptoms, and those with a stroke. If we take screening to a younger population and an asymptomatic population, then there is probably very weak evidence that we can prevent stroke. Why? Number one, because the disease prevalence is going to be lower. The risk of subclinical and short episodes of atrial fibrillation is not high, but the risk of antiarrhythmic drugs is also not low, and the risk of oral anticoagulation is also not low. So how can we manage a patient that comes to you and he has a pacemaker, for instance, and it shows some rapid irregular atrial activity? It depends on two variables. Number one, the burden of these atrial activity, and number two, the famous Shad-VASc score. If the Shad-VASc score is high, then of course they better be anticoagulated. If the Shad-VASc is low, then we should think. If the burden is between 5 minutes and 1 hour, then the chances that they develop atrial fibrillation is really low. But between 1 hour and less than 6 hours, then these patients are likely to develop clinical atrial fibrillation. And we had an important trial published in the latest ESC that looked at patients above the age of 65 who have a SHAD-VASc score of more than 1, and they all had pacemakers. And the pacemaker detected rapid atrial rates, but the patient was asymptomatic. We know that this can be a precursor of atrial fibrillation. Half of them will develop atrial fibrillation. But when these patients were anticoagulated with a NOAC, there was no difference in the primary endpoint of stroke or death, and there was also no significant difference, or even there was more bleeding when we give them an oral anticoagulant. So the mere presence of high atrial rates by a pacemaker does not automatically mean that we need to anticoagulate these patients. We need to look into the burden, how frequent and how long, and we need to look into the SHAD-VASc score. If the episodes are frequent and long, and if the SHAD-VASc score is high, then we can consider oral anticoagulation. After we diagnose atrial fibrillation, digital devices are still useful because they can tell us the burden of atrial fibrillation. We tell the patient to check his ECG with a portable device or the smartwatch or the mobile phone for 2 weeks before visiting the doctor, or for 2 weeks every 6 months. And then through these softwares, they have an interface for the patient and an interface for the doctor. So we can estimate the burden of atrial fibrillation and modify the treatment accordingly. And as I said, creating a program for screening of atrial fibrillation needs to consider many factors, especially in the European community where data privacy and data safety are among the top priorities. So you need to be surrounded by good IT people who can take care of the patient's data and the patient's privacy. So to conclude, to screen for atrial fibrillation, you need to be justified and cost effective. And this is among the elderly, multiple comorbidities, and cryptogenic stroke. We have multiple devices and wearable. Some of them are medical devices like the loop recorder and the pacemakers and the Holter monitors and the ECG patch. Some of them are commercially available like the smart bands and the smartwatch. We need to understand when to use which device. What to do with subclinical atrial fibrillation depends on the frequency, the duration, and the risk of stroke. I revised the guidelines and summarized the European Heart Rhythm Association guidelines on wearable devices in 3 videos. You can scan the QR code. It will take you to those videos. I think it would be a nice extension of what we mentioned in this lecture. Thank you so much.
Thank you so much, Dr. Hussein, for this great lecture and interesting data you presented, which I learned a lot about more about this screening, especially for silent atrial fibrillation. I definitely will have some question toward the end. So we'll go for the next lecture with Dr. Amir. He's going to talk about dual versus triple therapy in patients with atrial fibrillation coming with acute coronary syndrome. Dr. Amir.
I just wanted to thank you for inviting me to take part of this educational session. And I'd like to thank Dr. Hassan for this wonderful talk that he just gave us. Very informative. Thank you very much. So today I'm going to talk about antithrombotic therapy in patients who require anticoagulation, predominantly non-valvular AF, and who also require antiplatelet therapy because they either developed ACS or underwent coronary revascularization in the form of PCI. So it won't be data heavy. It's going to be short and sweet, and it's going to be, I hope it be very pragmatic and focused on tips and tricks and things that we can learn and how to manage these patients. So this is my outline of my talk. I'm going to talk a bit about the background of the scope of the problem. Talk about some tools we can use to define bleeding and thrombotic risks, and then how we decide the type of agents that we use and the duration of therapy, or as I like to call it, when to drop aspirin. Is essentially that's the main question: is when do you drop aspirin? And then at the end, I'll summarize with a few recommendations and some differences between the guidelines between the North American and the European guidelines. So, as I just mentioned, and as Dr. Omar just mentioned, in patients, who develop AF, the consequences of AF can be debilitating. And in patients who have AF who need PCI, we're faced with a day-to-day clinical conundrum in balancing bleeding risks and thrombotic risks, because up to 40% of patients with AF also have underlying coronary artery disease. Many of them will need revascularization, and for those who undergo revascularization, the majority of them will undergo PCI. So balancing the risk of bleeding and the risk of thrombosis is challenging in clinical practice. At least I find it challenging, especially in elderly patients. And so hopefully by the end of this talk, we can have some tools to try to understand how to navigate this conundrum. It's well known that the combination of an oral anticoagulant combined with dual antiplatelet therapy substantially increases the risk of bleeding. And bleeding after PCI has also been shown in multiple studies to be associated with increased morbidity and mortality. This is a graph from a post-hoc analysis of the ADAPT-DS study, which looked at platelet reactivity in patients treated with clopidogrel undergoing PCI. And as you can see here, that the solid line is all-cause mortality, and the dotted line is cardiac mortality. In patients who experience post-discharge bleeding, their mortality is significantly higher than those who don't have any post-discharge bleeding. So bleeding is associated with increased morbidity and mortality. The majority of the evidence that's shaped how we manage patients on triple therapy or double therapy primarily comes from 4 randomized controlled trials, as well as several recently published meta-analyses. But the majority of the randomized controlled trials, contemporary controlled trials that utilize NOACs, are the Pioneer AF PCI study, which used rivaroxaban, published in 2016, Redual PCI that utilized dabigatran, published in 2017, and Augustus using apixaban in 2019, and Intrust AF PCI using edoxaban in 2019. The pivotal study, I haven't mentioned another pivotal study, the WOES trial and the ISAR triple studies. These did not use NOACs, and these primarily used vitamin K antagonists. So this slide summarizes the results of the main DOAC studies that looked at comparing double therapy versus triple therapy. These 4 trials primarily compared, in a nutshell, primarily compared a DOAC with a P2Y12 inhibitor versus triple therapy using, for example, warfarin or a vitamin K antagonist, a P2Y12 inhibitor, and aspirin. And across the board, it's been shown that there's significantly reduced bleeding with a combination of a DOAC and a P2Y12 inhibitor. It's important to know that in all of these studies, all of the patients were loaded with aspirin and had a few days of aspirin peri-procedurally. So they all had aspirin, but the aspirin were dropped at different times during the trials, and the eventual control arms involved comparing a DOAC with a P2Y12 inhibitor versus warfarin and dual antiplatelet therapy. As you can see, the patient populations primarily included patients who underwent PCI, and in some of the studies, approximately 50% of them had ACS. And in the Augustus trial published in 2019, there's approximately 24% of patients who were medically managed. So to summarize the results of these 4 randomized controlled trials, the use of aspirin in patients assigned to double therapy, so NOAC plus a P2Y12 inhibitor, was limited to the peri-PCI period. And we'll talk about what's the peri-PCI period later, but it's generally speaking at the time of admission and until the time of discharge. That's generally, ranging anytime between 1 to 7 days. Double therapy was associated with a large reduction in bleeding compared with triple therapy, where aspirin was continued. In particular, there was more bleeding in patients who were on warfarin. It's important to know that none of the randomized control trials were powered to assess major adverse cardiovascular events such as stent thrombosis, stroke, or re-MI. However, despite this, there was no significant signal to suggest an increase in thrombotic complications in those who took double therapy compared to triple therapy. However, several meta-analyses have shown that there is a signal towards an increased risk of thrombotic complications in patients who are on double therapy, as well as in the Augustus trial, there was a numerically twofold increase in the rates of stent thrombosis in those patients who had aspirin dropped. So therefore, these observations, make us want to think is for every patient that we put on triple therapy, when is the right time for that patient to drop the aspirin, bearing in mind the risk of bleeding and the risk of thrombosis. So this is a meta-analysis published in 2019 by Gargulio and colleagues, and this really combined the 4 trials that I just talked about: Augustus, Entrust, AFPCI, Pioneer AFPCI, and Redual PCI. And this compares essentially dual anti-thrombotic therapy, which is DOAC plus a single antiplatelet agent, versus a vitamin K antagonist plus dual antiplatelet therapy. And this slide shows that with dual antiplatelet therapy, there was a significant increase in stent thrombosis, as you can see in this slide. It's about 60% increase in stent thrombosis, which was significant. And there was a trend toward higher risk of MI, but that wasn't significant. The p-value was p.07 over here. So there's a signal toward increased risk of MI, but a significant increase in stent thrombosis in those on dual antithrombotic therapy. This was conducted using a random effects model. And then in the same year, another meta-analysis published by Gali, published in Eurospace, looked at the same problem, and they found similar results. There was also a significant increase in the rates of stent thrombosis. They thought there wasn't much heterogeneity in this meta-analysis, so appropriately, I guess, they used a fixed effects model, whereas the previous meta-analysis used a random effects model, but the results were the same. There was about 60% increase in stent thrombosis, which was significant. And there was a trend toward higher risk of MI, which became significant in the ACS-PCI subgroup. There was a 40% increase in the risk of MI, which was statistically significant. So bearing that in mind, we need to be able to define for our patients, the bleeding risk and the thrombotic risk. So what tools can we use to try to understand for each particular patient, how do we understand the balance? So I like to use the Academic Research Consortium definition of bleeding risk, and so separates them into major and minor. Major risks, obviously, if if the patient's already taking oral anticoagulant, that's already a major risk. But excluding that, there are other things we can look at: severe end-stage chronic kidney disease, hemoglobin of less than 11, so anemia, previous spontaneous bleeding, thrombocytopenia, and several others. And there are some minor criteria. As you can see, moderate chronic kidney disease, age greater than or equal to 75, a mild degree of anemia, and long-term use of steroids or non-steroidal anti-inflammatory drugs. High bleeding risk, according to Academic Research Consortium, is defined as one major, other than the use of an oral anticoagulant, or two minor criteria. And how do we define thrombotic risk? Thrombotic risk can be thought of as in the context of the patient and the procedure and the situation. I guess the situation could be: are we dealing with chronic coronary syndrome, or are we dealing with an acute coronary syndrome? patients with acute coronary syndrome had an increased risk of thrombotic complications, particularly as several randomized controlled trials have shown that this is highest within the first month. The patients who had previous episodes of stent thrombosis whilst on antiplatelet therapy are certainly at very high thrombotic risk. And the complexity of the PCI being performed. If there's more than 3 vessels treated, greater than 3 stents implanted, greater than 3 lesions treated, and so on. Particularly important if the patient, if there's, for example, a left main PCI or multiple stents in a bifurcation lesion, and some people would consider a single surviving vessel, even though it may be a simple PCI and a single surviving vessel, that might be also relevant. So, and a lot of guidelines and some experts also say that the balance, this should weigh more. The bleeding risk should weigh more than the thrombotic risk. So you should always, I don't think they're equal. I think if someone has, if they're at risk of bleeding and at risk of thrombosis, you should pay particular attention more to the bleeding risk, because the consensus seems to be the bleeding is significantly more important and more clinically relevant than the potential risk of thrombosis. So I'm going to talk about now the choice of after we've determined the bleeding risks and thrombotic risks of our patient, and we need to, commence and they're in AF, and we need to start them with essentially triple therapy, whether they're already on an anticoagulant or whether they weren't on an anticoagulant. How do we decide which anticoagulant to use? So obviously, I know because of multiple recent studies, a NOAC is preferred over a vitamin K antagonist because of the lower risk of bleeding across the board in multiple previous studies published. So a NOAC should always be preferred in suitable patients in the absence of contraindications. And this is, stems from the consistent reduction in bleeding complications with a NOAC compared to vitamin K antagonist. The selection of a specific agent, which NOAC to use, should take into consideration the trial that it was designed to try to fit the patient as close as possible to a certain trial. At least that's what how I like to think about it. Because each trial there's subtle differences in the 4 of the trials that were designed. And so you try to fit the patient to as close as possible to the design of the trial. And that way you can at least know that the results of the trial can be extrapolated to the patient that you have in front of you. So some interesting or notable differences, I've thought I'd summarize some notable differences between the trials here. Pioneer AF excluded patients with previous strokes. Entrust AF PCI was the only trial that did not show superiority in bleeding reduction of a NOAC versus a vitamin K antagonist, although non-inferiority was met. Augustus was the only trial to actually independently compare a DOAC to a vitamin K antagonist, and also to assess in a randomized fashion the effective aspect. These 4 trials that use the 4 DOACs, all except for one trial, all of them use the appropriate doses that are approved for stroke prevention. The only one that used a reduced dose was the Pioneer AF trial, in which rivaroxaban was used at a dose of 15 milligrams, and that was reduced to 10 milligrams in certain situations, particularly if the creatinine clearance was reduced. And also, there was another arm of the study which used 2.5 milligrams twice daily along with dual antiplatelet therapy, which isn't one of the options for stroke prevention, as we all know. Therefore, if you are going to use rivaroxaban, the 15 milligram dose rather than the 20 milligram dose should be used in the setting of double therapy. And then once that time period is over for double therapy, patient should be transitioned to the appropriate monotherapy dose for thromboembolic protection, which is 20 milligrams. This is for rivaroxaban. In redual PCI, the trial looked at dabigatran at 2 dosing regimens, 150 milligrams with a P2Y12 inhibitor or 110 milligrams with a P2Y12 inhibitor. And the patients who were above 80 years of age outside of the US received 110 milligrams twice daily, and in Japan, greater than 70 years of age. the patients who are on 110 milligrams of dabigatran, there is a slightly increased risk of ischemic complications in terms of thromboembolic protection. Therefore, if you would like to use dabigatran and the patient is considered to be a high thromboembolic risk, but not at high bleeding risk, then you can consider using the higher dose of dabigatran, which is 150 milligrams. But if the patient is at a high bleeding risk, then 110 milligram dose is recommended. I won't talk much about this slide because we already mentioned that in the Augustus trial, apixaban was used at the appropriate dose for stroke prevention, so 5 milligrams twice daily. And that's the appropriate dose for stroke prevention. And as I mentioned before, Augustus was the only trial that actually, by nature of its design, compared directly a NOAC to a non-vitamin K, to a vitamin K antagonist, and also compared aspirin to placebo, so the effect of aspirin on bleeding complications. Entras PCI used edoxapan at a dose of 60 milligrams once daily, or a reduced dose depending on the renal function and other concomitant medications that could inhibit the metabolization of edoxapan. And this is the approved dose for thromboembolic protection and most drug regulating authorities. Okay, so we talked about the anticoagulant choice. Now we're going to talk about what type of antiplatelets. And this one's easy because most of the trials mandated aspirin in the peri-PCI period. So if you're going to, someone is come in on a DOAC and PCI is being planned, you should load them with aspirin, and they should be commenced on aspirin in the peri-PCI period, at least during the inpatient stay. And the P2Y12 inhibitor that should be used ideally should be clopidogrel, as that was used in approximately 90% of patients enrolled in these trials. Strategy. When I refer to strategy, I refer to the really when do you drop the aspirin. That's what I mean by strategy. Is double safer than triple therapy, and how long do you keep them on triple therapy if you do need to keep aspirin going? When you drop the aspirin, it becomes double therapy. If you keep the aspirin, it stays triple therapy. So the totality of the evidence demonstrates a significant reduction in bleeding complications in patients with double therapy, as we just discussed. Although none of the RCTs were powered to look for thrombotic complications such as stent thrombosis, there was no signal to suggest an increase in ischemic events. There were, however, several meta-analyses which we discussed that showed there is maybe a potential signal there. So we need to just think about our patients, think about the procedures, think about the situation, and make a decision qualitatively as to how long do we keep the aspirin going. So what is the peri-PCI period? Usually in the literature and in the trials is defined as the period from time of PCI to randomization. And that ranged between 0 and 14 days. And you can see here in the table, the median time for the trials. For Pioneer AF, the median time, the average time was 1 day. Redual PCI was 1 day. The Augustus trial used the apixaban was 6 days, and Entras AF PCI was about 2 days. So you could generalize and extrapolate from this that usually for most of these trials, on average, the patients received aspirin for approximately a week before they were transitioned to double therapy if they were randomized to double therapy and to drop the aspirin. So based on the evidence from these trials, most of our patients, aspirin should be ceased after 1 week. So that should form the majority of your practice and the majority of your patients. So if your patient is on a oral anticoagulant, aspirin should be ceased at 1 week, unless there are compelling reasons such as risks for thrombosis or ischemia, and that should be balanced with the risk of bleeding. In the absence for major criteria of bleeding, it is reasonable, according to both the European and North American guidelines, to continue aspirin for up to 1 month after PCI in patients with high thrombotic risk. So that really should be the time limit or the ceiling of how long do you keep the aspirin going. But from the majority of the patients, they should be either stopped at discharge or stopped within 1 week. This is a post hoc analysis of the Augustus trial, and I really like this slide because it shows the equipoise between bleeding and between thrombotic complications. On the left, you have days to up to 30 days. So patients, this is comparing aspirin versus placebo in the arm of the in the Augustus trial. So the use of aspirin for up to 30 days. So if you use aspirin up to 30 days and didn't drop the aspirin, there's equipoise between bleeding and thrombosis. So the bleeding rate that seen with aspirin is offset by the reduced thrombotic risk. However, after 30 days, which is the column on the right, aspirin continues to increase the rate of bleeding. However, the protection from thrombosis is no longer there. It is no longer offset because whether or not the patients are on aspirin, they experience the same thrombotic risk. Therefore, after 30 days, really no one should still be on aspirin. Just going to briefly summarize now. So therefore, in patients with AF undergoing PCI, NOAC is the ideal anticoagulant of choice. And the dosing regimen should be that recommended by the trial that established the dose for thromboembolic prophylaxis for stroke. So therefore, if you're using rivaroxaban, it should be 15 milligrams. And the other doses should be according to the previous trial establishing the dose. Lower doses should not be used. DAPT should be given to all patients in the peri-PCI period. So everyone should receive aspirin, a P2Y12 inhibitor. And aspirin should continue until discharge or 1 week. And in very few cases, if the thrombotic risk is very high, up to 30 days. Beyond 30 days, aspirin therapy is not recommended. In terms of where to go after that, double therapy should be continued. So double therapy is, the DOAC plus the P2Y12 inhibitor could be continued for 6 months. In, for example, patients with stable ischemic heart disease, and then the P2Y12 inhibitor could be dropped, or it could be continued up to 12 months in patients with acute coronary syndrome because there's a higher thrombotic risk. After which, after 12 months, the majority of patients should remain on a DOAC without any antiplatelet therapy. And this is a summary. So this is where most of your patients should lie in, the default strategy. And this is a figure I got from an update from the North American guidelines, consensus guidelines. The default strategy should everyone get aspirin, a P2Y12 inhibitor, ideally clopidogrel, and then up to 1 week, you can choose triple therapy, drop the aspirin, and then double therapy for up to 12 months, followed by oral anticoagulant therapy alone. In patients at high ischemic risk, you could increase the duration of triple therapy to 3 months, and then transition to double therapy up to 12 months. In patients at high ischemic risk, in patients at low ischemic risk but high bleeding risk, you minimize triple therapy, so 1 week or pre-discharge, and then you could also reduce double therapy. Instead of 12 months, you could reduce it to 6 months, followed by oral anticoagulation alone. Comparing this to the ESC guidelines, they're pretty much the same. The only difference is the North American guidelines mention a peri-PCI period, which suggests that probably the advocate for a shorter duration of triple therapy. So if the patient's discharged on the 2nd or 3rd day, they'll probably drop the aspirin, whereas the European guidelines tend to push for at least a week of triple therapy, regardless of there's a fixed period where it's recommended to use at least a week. And the maximum is the same. It's recommended no more than 1 month, ideally, and then followed by either 6 months or 12 months, depending on the presentation. Thank you very much.
Thank you so much, Dr. Amir, for this great presentation and update. And as you review, it is so tricky to figure out what to do because there is risk either way, and so it's very tricky to figure out exactly when to stop aspirin, but you give a very great guidelines how to when to manage the stopping the aspirin, because it really depends on the patient. So that's was a really very nice presentation. We'll see if we can. Do you have any questions? Just in the meantime, waiting for some questions from the audience. So you said that, of course, balance between the risk of thrombosis and the risk of to the timing of the aspirin. The question is, do you take in consideration in that formula, do you take in consideration the risk of the CHAD-VAS score when you make this equation? Of course, when we talk about the risk of ischemia, as we meant usually the risk of coronary ischemia. And how about the risk of the stroke, the CHAD-VAS? Is it in this equation?
That's a very good question. I don't think it's in the equation as much as the risk of thrombosis, because the patient, you're not deciding about dropping the anticoagulant. You're deciding about dropping the aspirin. So you're targeting here a different mechanism, and so all these patients are already anticoagulated. I think what you're trying to prevent here is, at least as interventional cardiologists, is our dreaded fear of reinfarction, particularly stent thrombosis. Although if you look at a lot of the combined endpoints, stroke was one of them. So a lot of these signals that we see, stroke is one of the combined endpoints. But it is certainly something that I think about, but I don't think it's a determining factor. If I would say it would be more the clinical context, the patient's presentation. It'd be more about the complexity of the PCI, for example, and whether or not the patient has a previous coronary thrombotic event. What do you think, Dr. Omar? How would you tackle this question?
It is very tricky, actually, and it came to my mind. If, of course, I don't think it has been studied, but if the patient have low CHAD-VAS score, borderline, like patient have CHAD-VAS score 2, and you end up with complicated coronary artery disease, and instead of dropping the aspirin, you may drop anticoagulation. This is not the guideline. This has not been studied. It just came to my mind, because really at the exactly what you said, what we're scared of is have a recent acute coronary syndrome with multiple stent or bifurcation stent or left main stent. And so you would rather to have a very full dual antiplatelet, and if the patient have low risk of stroke, to drop the anticoagulation for a week or a couple of weeks or a month probably. But this is not the guidelines. This is not going, just for interest of discussion. And probably we don't need to discuss it further in this particular meeting, but something, some thought came to my mind in that particular way. Anyway, so we have a question here for the management of patient with paroxysmal atrial fibrillation and lone atrial fibrillation. I guess we can talk about anticoagulation. So you can, Dr. Hussein, and then Dr. Amr may take that one.
Yes, thank you, Dr. Omar. The term
Lone AFib and paroxysmal AFib, yeah.
The term lone atrial fibrillation is largely disappearing from the medical literature. We now don't think of lone atrial fibrillation or atrial fibrillation caused by a disease, because we know atrial fibrillation is multifactorial. We have now comorbidities for atrial fibrillation. So we decide the management of atrial fibrillation on two domains: stroke, systemic embolism prevention, and then rhythm or rate control. And for stroke or systemic embolism prevention, it's largely dominated by the CHAD-VAS score. And we know 1 in men and 2 in women. For paroxysmal atrial fibrillation, the same rules apply. Now, for paroxysmal AFib, we need to think of the patient's symptoms. And if the patient is asymptomatic from these paroxysms, then there's probably no major point in giving a rhythm control strategy. But if the patient becomes markedly symptomatic during the paroxysm, then we need to think of something. And these would be either antiarrhythmic drugs, AEDs, and probably an attractive alternative then would be the pill in the pocket, which could be propafenone, 150 milligrams when the patient takes them, or 300 milligrams if the patient takes them whenever he gets the paroxysm, and they seem to be working. The other tool would be ablation, and we keep that for those paroxysms that are disturbing the patient's life or the paroxysms that are associated with heart failure.
Excellent. Just before we have Dr. Amer to mention, the lone AFib, I understand this terminology not being used often, but actually in our area here, we probably will see a lot of, if you want to call it lone AFib patients. I see, probably you see also patients in their 30s and early 40s who just have atrial actually, have no other problem except atrial fibrillation. Of course, that put them at low risk of having stroke, but you deal with the rhythmic part of it if it's symptomatic or asymptomatic, treating the arrhythmia. But for anticoagulation, usually they have no other risk. For some reason, I've seen much more patients with atrial fibrillation in their 30s here in Dubai than what I see when I was practicing in other countries. Because I'm sure there's the population here is young, so you're going to see lower age in those patients. What do you think, Doctor? Question on for the atrial fibrillation, do you anticoagulate the same as permanent or chronic? You do the same, or you have any different strategy?
I agree
versus
I agree with Dr. Hussain. I think I'm guided by predominantly the CHA2DS2-VASc score, and I think that's what should be driving the most of our decisions. That has the most of the evidence comes from that strategy, and with what you said about seeing a lot of atrial fibrillation in younger patients, I think it's interesting. It's because I guess the majority of the patients you see, I guess, are young, so therefore you're more exposed, at least in your head, to that, rather than you don't think of the 70 or 80-year-old with AF. You see them, you stop thinking about them, but maybe you think more about the 30-year-old or the 35-year-old with AF more.
Exactly. Now there's a question. Probably it says here: is there any evidence for patient who need atrial ablation? Probably, I think it is after ablation. Do you still need NOAC? What do you think, Hussain?
Yes, the answer is yes. I tend to think of again, it's dictated by the CHA2DS2-VASc score. The ablation, the success of ablation, let's say it's 70 or 80 or even 90%. And that's the acute success. But atrial fibrillation is associated with a form of atrial fibrosis and myopathy. So these driving factors or the substrate, they can come again. And so I believe that once atrial fibrillation, there's always atrial fibrillation. It will always be looming in the background, like the insects you have in the cracks of the wall. You can spray the insecticide and you think that you got rid of them, but they are still there hiding. And once the right time comes, the atrial fibrillation will show up again. And even ablation itself is associated with some risk of stroke, I mean the procedure. So ablation is useful for symptomatic relief, but its impact on stroke, honestly, I'm not sure about that.
So, Dr. Amer, if a patient underwent ablation and you did long-term monitoring, there is no recurrence of atrial fibrillation, do you have to continue anticoagulation? Like if you are monitor for, you put the loop recorder, and loop recorder after 1 year, 2 years, there is no atrial fibrillation. Do you want fibrillation or you stop?
So I think this is a perfect situation where you have to involve the patient in the decision, because this is you have to inform him of what the what you know and what you think you can predict, and what you're limited by the possibility of AF, as Dr. Hussain said, can come in at any time, because as the person ages and as they exposed, your exposure is not constant to certain risk factors and changes. So even though, for example, after 2 years, there's not a single sign of atrial fibrillation, it wouldn't be unreasonable, as long as the patient's aware that he's happy to stop it, and understands that his risk might change the day after, although low. I think it's not unreasonable, particularly if his CHA2DS2-VASc score is low. I think that is a situation, if you involve the patient, you can certainly stop the anticoagulation. But I would be wary if the patient has a very high CHA2DS2-VASc score. And for example, even though for 2 years there's no atrial fibrillation detected, he has a very high CHA2DS2-VASc score, but has a low risk of bleeding, where the benefits of anticoagulation certainly outweigh any risk of bleeding, I'll be probably more inclined on keeping him on the anticoagulation.
Exactly. Back to again to your presentation, is balancing the risk benefit and make the decision after have very good way of the risk and benefit of the patient. We have a question here: is in AFib patient and PCI in elderly, it is known that elderly have a higher risk of bleed, and so they receive the short triple therapy period for 1 week, then double therapy for 6 months, and then NOAC alone. Is that the summary, Dr. Hussain?
Is it for me or Dr. Amir?
For both of you, actually. Dr. Amir. Dr. Amir, is that what, if you want to summarize high risk of bleed, you have a triple therapy for 1 week or 1 month, and then dual therapy for 6 months, and then monotherapy after that. Is that
correct? Correct. Yeah.
What
you determine
recommend?
if they're at high bleeding risk, you would treat them for 1 week, followed by dual therapy for 6 months, and then you can drop the P2Y12 inhibitor. Yeah. Super.
I have a question here. I'm reading what is the question said, but probably, do you use apixaban for bedridden patients? So I don't know what they meant by that one.
He's speaking of the frail elderly.
I'm sorry?
I think he's speaking, the question is about the frail elderly.
Yeah, this patient is bedridden, so he's not good to fall. So he's already in the bed, and but
but more reason not to anticoagulate them. I mean, if he's frail and bedridden, that might also be a reason as to maybe you wouldn't want to anticoagulate them, depending, I guess, on their quality of life.
Okay. Now, Dr. Hussain, the question is about that screening for silent. I mean, if the patient have symptom, probably the management is easier. But if the patient is silent, have a multiple risk factor for atrial fibrillation, 60 years old or 65 years old. And I mean, let's say you put a Holter monitor and you have 2 minutes or 5 minutes or half an hour of atrial fibrillation automatic at night. What do you do?
I think we lost the sound.
Dr. Hussain?
Yes, I think I lost part, but what I understood is that we're talking about a 60-year plus gentleman.
The question is silent atrial fibrillation. 2 days Holter monitor shows 10 minutes AFib, asymptomatic. What do you do?
Well, if we want to take just a cutoff, a sharp threshold, it will be 5 minutes. Shorter than 5 minutes, then the threshold for anticoagulation would probably needs to be very high. We need to be justified to do that. Longer than 5 minutes, then we start to think of that these are true paroxysms, and based on the natural history of atrial fibrillation, these paroxysms are likely to become more prolonged until they amalgamate and they become permanent. And in someone who's 60 years old and he has some comorbidities, then more than 5 minutes, yes, I would be inclined for anticoagulation.
The 5 minutes over how long of monitoring period? Over 1 day, 1 year? I mean, because it really depends how long you have to monitor to give you the 5 minutes. So, I mean, the 5 minutes after how long of period?
We usually, the commercially available in most hospitals is 24 to 48 hours. So if we have more than 5 minutes in 24 hours, then we know statistically that these patients, more than 1/3 of them, would develop clinical and classic paroxysmal and symptomatic atrial fibrillation down the line. And considering the SHAD-VASc score, if he's above 60, then he's probably going to have some comorbidities. Then his SHAD-VASc score would probably qualify him from the thrombotic risk side. And when he crosses the 5 minute or 6 minute duration, then atrial fibrillation is real. It's subclinical, but it's real.
You mentioned about the atrial fibrillation load. I mean, as if you're going to make decision after 5 minutes, what make any difference if it's a 6 minute or 23 hours?
Here we're going into gray zones. I wanted to make it easier and say, if we have a cutoff of 5 minutes, then that would be enough. But in fact, it could be 5 minutes to 1 hour, 1 hour to 6 hours, 6 hours to 12 hours. And it's a graded relation. As the duration increases, I can show the slide again. It's from the ESC guidelines. As the duration...
We remember you showed because before, I mean, that was a debatable issue, is how long you have to have atrial fibrillation to anticoagulate. And there was agreement before 2 hours, and then it dropped to half an hour, and now you have 5 minutes. But the idea is, if you're going to make decision on anticoagulation or not anticoagulation, if you have more than 5 minutes. So why you have to bother and see, is it longer than 5 minutes? Because you're going to make decision anyway. I mean, SHAD-VASc, you take the SHAD-VASc and make decision if it's 6 minutes or 23 hours. So I want the idea of atrial fibrillation load for anticoagulation purposes, not for the antiarrhythmic purposes.
Because we may run into situations where the patient bleeds.
Okay.
And then we would go into a tough question of what should we do about anticoagulation? And then if the load is low and the duration is short, then we can feel safer towards de-escalation of novel anticoagulants, or even temporary holding of novel anticoagulants, or referral for left atrial occlusion device. Whereas if the burden is high and the duration is long, then we need to be more inclined towards anticoagulating them and tolerating the risk of bleeding. It's a graded relation.
Yes, yeah. I mean, it is, as you said, it just in case you bleeding or complication, then probably that's the load may help you to make a decision about stopping or de-escalating the anticoagulation, lowering the dose and so on. But to decision to start the medicine, start the anticoagulation, you do not need the load. If you have a SHAD-VASc 4, you have 7 of anticoagulation, that's it, right?
Yes, doctor. I lost some of the question, but yes.
Okay. Yeah, I'm sorry. The idea is the duration of atrial fibrillation is for starting coagulation, and the idea of the load is to stop the anticoagulation in case the patient bleeds.
Yes.
Okay. There's a question here. I mean, if not or crash apixaban, or it is not applicable. That the question of prevention. So they send another kind of clarification of the question. Can you and have it as a liquid or
So is the question, can you have apixaban as a syrup? Does it come as a syrup? Is that the question, or can you crush it?
The question, I think, is can apixaban be crushed for someone who's taking Ryle nasogastric tube feeding? And the
yes.
answer is
yes.
Good. Well, we don't have any more questions from the audience. I don't know if Dr. Amir or Dr. Hussein want to add anything or have any questions yourself for the panel.
I have a question for Dr. Hussein. What's his favorite device to use in a young patient? This is from your experience. I'd love to know what's your. I know you have no disclosures or affiliations, but I'd love to know what's your favorite device that you recommend, Dr. Hussein.
I tell you, it depends. Young people are usually technology savvy, but it depends on how the patient, what's the status during the paroxysm. If the patient tends to lose consciousness completely, then it has to be a PPG device like a smart band. Because to activate an ECG device like this watch, you need to start and click some buttons and then put your hand for 30 seconds, and you need to be awake and conscious and sane to do it. Whereas the PPG devices like the smart bands, for example, the Fitbit, they are constantly recording the heart rate, and they would give you a hint. So if the patient comes and tells you, I dropped at Friday at 11 a.m., then you can look at the log of the heart rate into the accompanying mobile app, and then you see what was his heart rate at that time. If the heart rate was fast, then there must have been something. If the heart rate was normal, then it's a nice exclusion test.
So for young patients, you like to use the PPG, is that right? The plethysmography devices.
It depends on the patient's condition during the attack.
Yes.
If he gets the attack the attack and loses consciousness, then his best option is the PPG device.
Thank you.
I mean, if the patient cannot activate the device, so we have to do something automatic. The last question is, for a cryptogenic stroke, how long do you monitor or which device do you use? Do you put the loop recorder implantable, or do you do something else especially for like 50 years old with the cryptogenic stroke?
The least I would do is an ECG patch for 2 weeks. Keeping in mind that we may probably need like 2 months to start seeing something. And as time goes on, atrial fibrillation appears more. If you looked at the curve, at 1 month, there's probably none. But at 12 months, it was 20%. At 36 months, it was 30 or 40%. So the longer, the better. And it depends on the availability, the cost, the insurance, and all of these issues. But for these patients, we need longer durations of monitoring.
I agree with that, especially for older patients. The longer you monitor, the more you're going to catch more of them.
Exactly.
So it's probably probably the vast majority of them will be those silent atrial fibrillation, especially at nighttime and so on. So probably monitoring, you will increase the yield of diagnosis.
Exactly.
And yeah. Well, if there's no more question, let me see if there's any other questions here. And it looks like we don't have any more. It was really very informative discussion, and I hope I learned a lot, and I hope that everybody in the group enjoyed this meeting. It was really nice, interesting, up to date, and thank you so much, both of you, for this outstanding presentation. Thank you so much, and I'd like to thank Pfizer for their supporting this education program. Thank you, and
Thank you,
good
Dr.
night.
Ali.
Thank you.
Thank you, everyone.
Bye-bye.